I see some of my colleagues here, so it's nice to get a little break from the deep freeze that we're having in Minnesota, although the weather isn't that great here either, but it is nice to get a little break. So today we're going to talk about renal complications, acute and chronic, in the setting of hematopoietic stem cell transplantation. As you can see, renal failure is not the same depending on the type of hematopoietic stem cell you get. For autologous stem cell transplantation, those patients actually experience much less of acute renal failure. And there are multiple reasons for this, which we'll go over in a little bit. The highest rates of acute renal failure actually comes in the Allo patients. As you can see, even by grading that grade 1, nearly half of the patients may experience some grade 1 renal insufficiency, which is defined by less than doubling of their serum creatinine. And grade 4 is up to 4%, which is dialysis. Now, some of the reasons behind the differences that we see is based on the diseases. So patients who undergo auto transplant mostly are myeloma patients, amyloid patients, and they do have a slightly higher risk of developing acute renal failure. Sickle cell anemia patients also come oftentimes with some underlying renal insufficiency, and so they are also at risk. However, the other conditions here are much more pertinent to allo transplant. So the conditioning regimen is typically much harsher than those for allo. GVHD doesn't occur in auto, so it's only occurring in allo transplants. And then VOD, or the new terminology SOS, sinusoidal obstructive syndrome, also mainly occurs in allo transplants. So if we take a look at what effect renal failure has on mortality rates after transplantation, you see that, again, grade 1 is less than doubling of the creatinine, which has some effect on mortality, about 20% mortality rate. But where you see the most effect is in those who are the grade 3s, patients requiring dialysis, where upwards of 80 to 90% mortality is seen in these patients. And the mortality occurs very quickly, usually within the first 3 to 4 months. So today we'll explore some of the causes of acute kidney injury or acute renal failure in these patients. These include acute kidney injury, which most oftentimes we'll call acute tubular necrosis or ATN, thrombotic microangiopathy, bone marrow transplant nephropathy, Engraftment Syndrome, viral nephropathy, chronic GVHD, and chronic kidney disease. What I won't go over is SOS because there are other sessions that are covering the sinusoidal obstructive syndrome. So when I go see a patient on the BMT unit, one of the first things I ask my fellow is, what day is the patient? Because that helps me frame what kind of diseases that could be occurring. So if it's before day 0, then tumor lysis syndrome is a possibility, or the patient has some underlying kidney disease from their either from their condition that they're going into transplant for, or just other causes. Now, hemoglobinuria only occurs on day 0, and this is mainly a event that occurs in bone marrow transplant. So I don't know how many of you have seen this occur, but it's one of the reasons why we give fluid and alkalinization at the time of stem cell infusion. So what happens is that in patients who have bone marrow harvest, you get a lot of erythrocytes contamination. And during the thawing and freezing, the erythrocytes break apart, and basically you're infusing hemoglobin right into the bloodstream. And hemoglobin is very toxic, especially to the kidney, and these patients will will actually urinate red urine during the time of the infusion. Again, this is something that happens right on day 0, doesn't happen afterwards. Conditioning regimen. Now, if you read papers on acute renal failure during stem cell transplantation, they always talk about conditioning regimens. But how many of you can think of a conditioning regimen that's nephrotoxic? I don't know of one, but everybody mentions it. However, I think that what they actually mean is the effects that the chemotherapy has on these patients. Some of them get pretty sick afterwards with nausea, vomiting, diarrhea, and it's probably that causes some of the acute kidney injury because, I mean, the most nephrotoxic agent that I can think of would be probably busulfan that you use for conditioning, because nobody uses carboplatinum for conditioning. So, you know, this one I think is more the effect of conditioning regimen rather than the conditioning regimen itself. Now, you can argue that radiation is nephrotoxic, but the nephrotoxicity from radiation doesn't occur within days. It occurs in months, so you don't see that right away. We're going to talk more about calcineurin inhibitor. As I said before, others are covering VOD, so I won't go into that very much. Transplant-associated thrombotic microangiopathy we'll cover in greater detail. Sepsis is something that these patients are at risk for from the time they go neutropenic. And in the Allo patients, actually much longer than you would see in the auto patients. So in auto patients, after they engraft, their risk for sepsis go way down. But that's not the case with Allo patients. So that's why it extends out way beyond 60 days. And then the chronic GVHD. So just to show you that the difference between Allo and auto patients, I hope these slides are projecting okay. So the difference in acute renal failure rates in patients with GVHD and without, and also patients with SOS and without. Again, since auto transplant patients rarely develop SOS and they very rarely develop GVHD, that's why the rates are different between the two groups. So the only thing I'm going to say about SOS is that it presents like a hepatorenal syndrome. So this is a syndrome that patients with cirrhosis get. And in fact, it actually mimics more of the Budd-Chiari syndrome, where you get the an obstruction of the hepatic vein. And what happens is that with that obstruction, you get splanchnic venous hypertension, which then causes renal vasoconstriction, and that causes the kidney to retain sodium. And that's why if you check a urine sodium on these patients, you will find that their urine sodium is often low. There's an 80% risk of acute kidney injury with SOS. And to be honest with you, I don't see this very much anymore because of the prophylactic use of defibrotide. So I can't remember a case of SOS I've seen in the last 2 to 3 years. Some people have also reported successful treatment with methylprednisolone as well. And there's poster 278 that covers the use of CDVH with SOS that was presented on Wednesday. Now, the second thing that I asked my fellow is what medication is the patient on? Because for nephrologists, the most common cause of in-hospital acute kidney injury is medications. And the medication list we're all pretty familiar with. Calcineurin inhibitors such as cyclosporin, tacrolimus. Amphotericin is quite nephrotoxic, however, ambisome is not. And they are not the same. So just because someone's on, people always blame ambisome, but make sure that it is the liposomal compound and not the straight amphotericin. Aminoglycosides are very toxic, foscarnet, and non-steroidal anti-inflammatories. Now, the moderate nephrotoxic drugs are Bactrim, penicillins, and cidofovir. And Bactrim can injure the kidneys in a number of ways. One, Bactrim actually interferes with the secretion of creatinine. So when you put someone on Bactrim, it's not uncommon that their creatinine will go up a little bit, 0.1, 0.2, and that's just due to a secretion blockade, so it has nothing to do with renal injury. However, Bactrim can cause acute interstitial nephritis, and so that's the most often thing that causes prolonged kidney injury. Penicillin is the same thing. It causes acute interstitial nephritis. And cidofovir is an antiviral that actually causes acute tubular injury. These are drugs that are often reported as being nephrotoxic, but again, I can't remember a case of acyclovir toxicity that I've ever seen in my 13 years, and if you include my fellowship, 16 years. It's been reported in patients who get really, really high dose of acyclovir, which most patients nowadays don't get. Same thing with getting cyclovir. Again, ambisome, the rates are pretty low. Not that it can't happen, but it's actually pretty low that ambisome causes nephrotoxicity. Cyclosporin causes much less nephrotoxicity than the penicillin. And vancomycin, this one is also very controversial. I had a medical student from Brazil come rotate with me, and he was literally shocked at how much vancomycin we use. And he goes, "Aren't you afraid?" I go, "Afraid of what?" He goes, "Nephrotoxicity." I said, "No." He said, in his hospital, every dose of vancomycin has to be okayed by a nephrologist before it can be given. I'm like, I don't have time for that. If that was the case, that would be all I do every day. Because, then I took him around the ward. I go, he's on vancomycin, he's on vancomycin, he's on vancomycin. I'm like, why don't you try to find me a patient that is not on vancomycin, and then we'll talk. So we do see elevation of creatinine with vancomycin, and it usually occurs when you have supertherapeutic doses. And the creatinine oftentimes will go right back down to baseline once you lower the dose and lower the level. So I don't want to let you or give you the impression that these are not nephrotoxic. They are all potentially nephrotoxic, and if you use them, in very high doses, they can be. But in reality, they're actually pretty low on the nephrotoxicity range. Now, I want to spend a little more time on calcineurin inhibitor because this is the #1 cause of acute kidney injury that I see in these patients. First thing is that calcineurin inhibitors causes a vasoconstriction as a dose-dependent phenomenon. And we see this in kidney transplantation, other solid organ transplantation, and especially in BMT patients. They can also cause a thrombotic microangiopathy, and I'll show you some data in a little bit. What's most important is that cyclosporin and tacrolimus are metabolized by the P450 system. And where we see patients get in trouble is when they start a macrolide antibiotic, such as Biaxin or a Z-Pak, the azole antifungal. Very commonly, they're doing fine, and then they get a fever, and they get started on fluconazole or whatever azole that they get on, and then their levels can double, and that's when they get in trouble. Calcium channel blockers, the non-dihydropyridine, such as diltiazem and verapamil, can raise the cyclosporin levels and tacrolimus level. Grapefruit juice is another known player that changes the level. And then this drug, fosaprepitant, which is an anti-nausea medication, can also block the P450 system. Now, if anyone is unconvinced about the effect of cyclosporin level on renal function, this graph should convince you. So the top graph is serum creatinine, and the bottom graph is tacrolimus level. I couldn't ask for a better example of tacrolimus toxicity than this one. Thrombotic microangiopathy. We see this quite a bit. And there is an entity called transplant-associated thrombotic microangiopathy. And this is considered to be separate than some of the other thrombotic microangiopathies that are known, so such as TTP, HUS, atypical HUS. And it does have some unique characteristics. So as we know, thrombotic microangiopathy is just another name for microangiopathic hemolytic anemia. And it is distinct from thrombocytopenic thrombotic purpura, TTP, in that in transplant-associated TMAs, the ADAM-TS13 activity is usually greater than 5. So in TTP, the ADAM-TS13 activity is usually less than 10. And the other thing about transplant-associated thrombotic microangiopathy is that it is not responsive to plasma exchange. We did a study at Mayo that was reported in a poster at ASH, and our response rate was about 25%, so less than a flip of a coin that they would respond, so they really don't respond to plasma exchange. Now, interestingly, the incidence in the literature ranges from 0.5 to 76%. And Dr. George, who's one of the leading experts in thrombotic microangiopathies in the U.S., believes that there's not a good definition, and so that's why there's such a wide range in the reporting. One thing that isn't disputed is that it is associated with a very high mortality rate. So there are actually two definitions now that are used for diagnostic criteria for transplant-associated TMA. There's an international working group which requires greater than 4% cystitis in the blood. De novo or progressive thrombocytopenia, I don't know how you would tell that in a patient that's day 10 after Allo BMT. Sudden and persistent increase in serum LDH, decrease in hemoglobin, or requiring blood transfusion and decrease in serum haptoglobin. The other definition is by the Blood and Marrow Transplant Clinical Trial Network Committee, and that just requires RBC fragmentation, and they only require 2 schistocytes per high power field. They also require elevated LDH, and they included renal toxicity in their definition as well. Also, they included other common signs of thrombotic microangiopathy, such as neurological dysfunction, and then a negative direct or indirect Coombs test. This is a study from Martinez in 2005 looking at different risk factors for transplant-associated TMAs. And the risk factors in this study that are most pertinent were donor type. So if you have mismatch donors, the risk goes up by 2 to 3 folds. Age is also a risk factor in this study. Patients greater than 40 had a 6-fold increase. Females also had more thrombotic microangiopathy in the study. And then acute GVHD is one of the major risk factors. Some of the other risk factors that have been shown in other studies, such as busulfan, TBI, calcineurin inhibitor, infection, and GVHD. Now, this slide just added recently came from an article that is in the current issue of BMT, showed that some of the other factors didn't pan out when you added in cyclosporin toxicity. And in fact, in this study, what they found was most significant for prediction of thrombotic microangiopathy were prior stem cell transplantation, grade 3 acute GVHD, and tacrolimus level greater than 25, which is fairly high. And then invasive fungal infections was borderline significant. So as you can see, these three factors canceled out all of the other ones. And so, again, your calcineurin inhibitor levels need to be monitored very, very closely. Treatment. I already told you that thrombotic microangiopathy from transplant does not respond to plasmapheresis. So really, a lot of the treatment is eliminating some of the factors, eliminating infection, reducing your calcineurin inhibitor dose. And if those don't work, people have used Eculizumab, Defrabertide, and Rituximab. This is another study that just came out this month, and it shows the use of Eculizumab in pediatric patients. And as you can see, following the use of Eculizumab, the CH50, which is a measurement of the complement system, went down significantly in most of the patients. Now, I have to say that in these 6 patients, 2 of them did not respond to Eculizumab. So Eculizumab is not a panacea for this condition, but it may offer an additional choice for treatment in patients that are resistant to the other treatments. BMT nephropathy. This is really another name for radiation nephritis. And it was named BMT nephropathy because most of the early BMTs were done with TBI. And again, this is a little bit controversial because we can demonstrate radiation nephritis in animals very well, but in humans it's not always reproducible. The presentation often occurs at around month 5 or 6 after allo stem cell transplantation or BMT. And these patients present with anemia, hypertension, elevated creatinine, proteinuria, microscopic hematuria, and edema. And so if you see patients presenting like this around 6 months after their transplant, think about BMT nephropathy. The renal pathology is consistent with the thrombotic microangiopathy, which really means it's an endothelial damage. Patient may or may not have actual cystitis in the periphery. There's only been one study, one randomized study looking at treatment of BMT nephropathy, and that's the use of captopril. And this was used in patients who underwent allo BMT, and the study was aimed for 1 year of captopril. Now, this study was criticized because most of the patients were not able to take captopril for an entire year. And so the conclusion you have to take with a little grain of salt, but basically they found that the incidence of BMT nephropathy was significantly decreased in the captopril group versus the placebo group. Again, most of the patients could not take captopril for an entire year, so whether this is valid or not needs to be confirmed with other studies. Engraftment syndrome. I think we all are pretty familiar with engraftment syndrome. Now, engraftment syndrome is one that can occur in both auto and allo transplant. And there are 2 definitions for engraftment syndrome. One is the Spitzer and one is the Malino. And the Spitzer defines it with major and minor criteria, where you have to have a fever, a rash, and non-cardiogenic pulmonary edema. And the minor criteria are hepatic dysfunction, renal insufficiency, weight gain of greater than 2.5%, and transient encephalopathy. Whereas the Malino criteria do not include renal insufficiency. They just look for 3 things: skin rash, pulmonary infiltrate, and diarrhea. And so for a while, there's a controversy as to whether or not renal insufficiency should even be included in engraftment syndrome. However, this study out of Korea showed that in their patients, and these patients mainly have leukemia, lymphoma, no patients with myeloma or amyloid. showed that 5% of these patients during their engraftment syndrome did have renal insufficiency. And the renal insufficiency happened right on the day that they were diagnosed with engraftment syndrome. Now, what we do know is that engraftment syndrome is much more common in certain disease types. So, for example, in patients with POEM syndrome, we find that about 30 to 50% of them may have engraftment syndrome. And in these patients, 10% of them may require dialysis because of engraftment syndrome. Similarly, we also found that in AL amyloidosis, engraftment syndrome is much more common, and about 8% of these patients had some acute kidney injury during their engraftment syndrome. The next thing I want to cover is viral nephropathies. There are several viruses that are known to attack the kidney either directly or indirectly. The one that is probably most common around the world is hepatitis C. And in hepatitis C, these patients develop cryoglobulinemia, which can affect the kidney. And they can also develop a kidney disease called membranoproliferative glomerulonephritis. However, this doesn't really pertain to us. The ones that do pertain to us is BK nephropathy. BK virus is present in about 90% of adults. So most of us were infected by BK at one point in our life. And the BK virus stays dormant in the uroepithelium. It gets reactivated during times of immunosuppression, so such as solid organ transplantation or hematopoietic stem cell transplantation. The disease is usually manifested as a hemorrhagic cystitis. So patients develop sudden growth hematuria. In fact, in some severe cases, they may actually present with bladder obstruction because the blood had clotted. But in rare cases, BK nephropathy has been reported. Now, most BK nephropathy has actually been reported in kidney transplantation. And so what we think happens is that the bladder gets damaged for whatever reason, and then viral replication occurs and is unchecked by the immune system due to the immunosuppression or conditioning. And then as the viruses replicate, further damage has occurred to the mucosa, and that's when the immunity returns. And actually, the immune reaction to the viral replication is just as important in the pathogenesis as the viral replication itself. BK reactivation is more common in T-cell depleted grafts and also in patients who use higher immunosuppression, such as calcineurin inhibitor plus mycophenolate. And this is what BK looks like in the kidney. So you have these cells with abnormal nuclei in the tubules that are infected with BK. And if you use an immunohistochemistry stain, you can actually see the BK virus along the cells and in the interstitium. Treatment for BK is very controversial. In fact, there's probably no one drug that has been proven to be very effective against BK. The most effective therapy is actually reduction of the immunosuppression. And that's what we do in kidney transplant. But this is not always feasible in patients with allo transplant. Others have used cidofovir, and in fact, if you look in the kidney literature, cidofovir is the most commonly cited drug for BK nephropathy. However, clinical trials have not demonstrated superiority over even reduction of immunosuppression. Another drug that has been cited is leflunomide. Leflunomide is a anti-worm medication that recently have been used for immunosuppression. And for some reason, this drug works, but it's probably because it is, when we put patients on leflunomide, we reduce the other immunosuppression, and it may be it's just reduction in immunosuppression. IVIG have been used by some people. However, this virus, as I said before, is dependent on T-cell immunity. So whether or not IVIG actually does anything is very controversial. And now I want to present you a case. This is a 25-year-old male that we saw in the hospital. He received an Allo transplant for CLL. Prior to transplant, he had 6 cycles of FCR, and then he had Cy-TBI for his conditioning. And he actually received a double umbilical cord blood transplant. And during his neutropenic phase, he developed neutropenic fever and had acute kidney injury. But he recovered. He recovered completely, and then his creatinine went up to 3.1. Following that, he developed gross hematuria. We did a CT of the abdomen pelvis, and that suggested that he had hemorrhagic cystitis. And then his fever returned, along with a cough. We did a BAL on him, and the BAL was positive for adenovirus. Eventually, because he had persistent renal failure, we did a kidney biopsy. And this is what his kidney biopsy looked like. So in histology class, they always tell us blue is bad. So it's the same thing with kidney biopsies. Blue is bad. And this shows a lot of mononuclear cells infiltrating the kidney. So this normally should not be here. And this patient has a rip-roaring granulomatous interstitial nephritis. And he also had cells that appeared to have some viral inclusion, similar to the BK nephropathy cell that I showed you a little bit earlier. Now, on viral stain, he does have virus particle in these cells, but these cells were not stained with SV40, which would detect the BK virus. These cells were stained with antibodies to adenovirus. So this is a patient with adenovirus that started in the lung and then ended up in the kidney with a granulomatous interstitial nephritis. Now this is his hospital course. So as you see, his creatinine actually went up to 7, and then we did a kidney biopsy. Once adenovirus was confirmed, we started on cidofovir, and you can see his viral count coming down, and as his viral count came down, his creatinine also came down, and eventually his renal function returned to baseline. Next, we'll talk about chronic GVHD. And chronic GVHD, from a nephrologist standpoint, is very different from the GVHD that you see acutely. From our standpoint, chronic GVHD presents as glomerular diseases. Most commonly, it's a disease called membranous nephropathy. We call it membranous nephropathy because the basement membrane, the glomerular basement membrane in membranous nephropathy is thickened. So normally, basement membrane should be about that thick, maybe even a little bit less. But as you can see, in most of the basement membranes in this kidney, they're much thicker. And on electron microscopy, you can see these electron-dense deposits depositing into the glomerular basement membrane. Now, for a while, it wasn't clear whether post-transplant membranous nephropathy was actually GVHD. But in one study, every patient with membranous nephropathy also had other features of chronic GVHD, showing us that it is probably related to graft versus host disease. The incidence currently ranges from 0.5 to 6% in non-myeloablative hematopoietic stem cell transplantation. The median time to development is 10 months to 2 years, so this is certainly not something that occurs acutely. Rather, it happens, usually my patients present at about a year's time. They present with high-grade proteinuria. Median range is 17 grams, so that's a pretty high grade. And there's definitely differences among the patients who develop membranous nephropathy after allo transplant versus those who are native. So both of them present with nephrotic syndrome. However, in the native patients, the non-transplant patient, we now know that about 60 to 70% of membranous nephropathy is due to this anti-PLA2R antibody. And the PLA2R is a receptor that is on the glomerular basement membrane, and this autoantibody attacks it. Well, in patients that develop membranous nephropathy after allotransplant, this PLA2R antibody is not found. So right there's a difference in the pathogenetic mechanism. Also, in the native disease, they are typically steroid non-responsive. However, steroid is the first thing I use on these patients, and most of them respond pretty well to just prednisone. Here's a patient that I'm following right now, and this is his proteinuria. His maximum proteinuria was up to a little over 4 grams. Started him on 60 milligrams of prednisone a day, and he responded very quickly. And as you can see, with this allowed me to taper him down to 10 milligrams a day, and he's on about 5 milligrams a day now, and his proteinuria remains actually quite low. Last time I saw him, it was about 300 milligrams. There are other renal pathologies that are associated with allotransplant. The next most common kidney disease is called minimal change disease. It's called minimal change disease because on light microscopy it looks normal. Thrombotic microangiopathy can also show up. Some patients have been reported to have tubular interstitial nephritis. Now this is very interesting because we rarely see acute cellular rejection in these kidneys. And it's been a problem that's been perplexing me for years. So if we take a kidney from someone and put it in a patient, if we don't give them immunosuppression, that kidney will reject. We'll have develop acute cellular rejection and sometimes acute humoral rejection. But if we put someone else's immune system into a person, that kidney doesn't reject. And so this tubular interstitial nephritis may be a form of rejection, but actually occurs very, very rarely. In fact, I haven't seen a case. And then IgA nephropathy has also been reported. Now, treating these patients are very tricky, and so I want to show you another case that I saw. This is a 55-year-old male with high-risk CLL. Received a transplant from his sister, and his conditioning was fludarabine with a single dose of TBI. The transplant was done on January 2011. And even before the transplant, he had this tuberculous mycobacterium skin infection that they were treating. Now, by day 30, he was a 100% donor on chimerism study. And he began having complications with GVHD pretty quickly with skin, lung, and GI tract. He also had multiple infections throughout. So 2.5 years later, he presented with a creatinine of 3.2. And at first, it wasn't really clear what was happening. He had gone on a camping trip with his son and apparently drank out of some fountain and developed diarrhea. So we thought maybe he was just dehydrated. And then he tells us after that he went to Europe and was backpacking with his daughter throughout Spain. And apparently the water was really expensive, so he didn't drink a lot. So anyway, that was the story he told us. But when we measured his proteinuria, it was 26 grams. So we immediately did a kidney biopsy. And what it showed was he had diffuse podocyte effacement. So you see this on electron microscopy. And that is very reminiscent of minimal change disease, or what we call podocytopathy. He also had areas of the kidney that had membranous changes, and on top of that, he had a thrombotic microangiopathy. So following this, the patient developed anasarca very quickly and hypertension. And we actually admitted him to the hospital for diuresis. He was getting very high doses of diuretic, and even with that, it was barely keeping his fluid off. He was started on prednisone on July 27th, and about 4 weeks later, one day, I walked in the room, and he coughed up a blood clot. You know, he wasn't really short of breath, he just coughed it right up. This was his chest x-ray on August 6th, and this was his chest x-ray the day he coughed up the blood clot. So 2 Goombas showed up. On CT scan, you see this cavitary lesion, and kind of the other one that you saw on chest x-ray. And it turned out to be an invasive fungal infection. He actually underwent right upper lobe lobectomy and a wedge resection of the middle lobe. He was started on ambisome and dulafungin. Prednisone was quickly tapered down to 7.5 milligrams a day, and he was started on mycophenolate mofetil. He actually required dialysis briefly. It wasn't clear why. He was actually transferred to the other hospital, and someone else was taking care of him, but it seemed like it was mostly for fluid management. But he was able to get off dialysis after about 5 weeks, and surprisingly, his creatinine came back down to 1.1 when I last saw him. And when I last saw him, his proteinuria, actually, this was about 3 months ago. When I last saw him, his proteinuria was actually down to about 2 grams a day. So, very fortunate for him, but as you can see, prednisone is not safe in these patients, and I always worry that if I keep them on it for a long time, they may develop something else. So oftentimes I will have to switch to a steroid-sparing agent such as mycophenolate mofetil, and more recently I've been using rituximab in these patients to act as a steroid-sparing agent. The last thing I want to talk about is chronic kidney disease. And chronic kidney disease is actually more common than most people realize. And I think that one of the reasons is that our Allo patients are now living longer. They're living long enough to actually develop chronic kidney disease. And how we define chronic kidney disease is an eGFR of less than 60. And in several studies, chronic kidney disease has been reported in 13 to 66% of adult patients undergoing Allo transplant, and equally high in pediatric patients. Hypertension is 10 times higher than the population, and it occurs 25 years earlier in patients who have undergone an Allo transplant versus those who do not. Now, we've talked about all the reasons behind why these patients would have chronic kidney disease. TBI, CNI, calcineurin inhibitor, chemotherapy, GVHD, BK virus, adenovirus. So all of those things accumulate, and what we're realizing in the nephrology world is that the kidneys have memory. They, even though the creatinine might go back down to baseline, the damage is already done, and we actually don't completely recover from that damage. And so anytime the patient develops any acute kidney injury, it will be additive for them later on in life. And these acute kidney injury will eventually translate into chronic kidney disease. Urine albumin has been shown to be quite helpful in predicting chronic kidney disease in the future. Now, in this study, they found that 37% of the patients at baseline, so prior to their Allo transplant, already had some albuminuria. By day 100, though, that rate almost doubled. And it remains high at 1 year. And in fact, almost all patients at some point during their transplant will develop albuminuria. And what does that implicate? Well, if you have albuminuria at baseline, usually it means that you're older, which makes sense. You're at risk for bacteremia about twice the rate as those who do not have albuminuria, and that you're at risk for acute GVHD. At day 100 to a year, usually we see this in HLA mismatch, women, and these patients are at risk for post-transplant hypertension and SOS. At greater than a year, albuminuria actually predicts for non-relapse mortality and bacteremia. Surprisingly, it was not associated with TBI or acute kidney injury in this study. And this is just showing you how the effect of albuminuria on overall survival. And this Kaplan-Meier curve breaks it down so that they're not dying of relapse disease. They're actually dying of something else, non-relapse mortality. So that's it, and I'll be happy to take any questions. I actually worked on the original cystatin C application for the FDA, so yes. The one thing about cystatin C is that it is mainly most helpful in patients that are either older or they have muscle wasting or very young. Because serum creatinine is dependent on muscle mass. So anyone who does not have normal muscle mass will have an abnormal creatinine, whether it is lower than it should be or higher than it should be, which mostly are in bodybuilders. And cystatin C eliminates that. Now the problem with cystatin C is that it hasn't really caught on that well. But Dr. Rule at our institution has written many papers on cystatin C and different formulas to calculate the GFR. And in certain cases, it is more accurate than the serum creatinine. So you can use cystatin C. It's just whether or not you can get it quickly at your institution. I mean, we run cystatin C just like we run creatinine. So for us, we get it within a couple of hours. But I know that not every place has the capability to run cystatin C.
Thank you.
Thanks very much. I wanted to know what your experience has been with using hyperbaric oxygen for hemorrhagic cystitis, or any thoughts about it.
We haven't used it.
Thanks.
I mean, most of the times these patients have BK nephropathy. I mean, almost always they have, unless they got hemorrhagic cystitis from high dose, if they got Cytoxan for their conditioning regimen, that's another possibility of having hemorrhagic cystitis. But hemorrhagic cystitis usually is kind of, self-limiting. So we haven't used it, but we also hadn't had the need to do anything beyond supportive care.
Thanks.
Thank you. I have two questions, actually. One is your experience using, do you use Cipro for BK? In our institution, some attendings will use it, some don't. And my other question is, having a hard time sometimes distinguishing between MAHA and TTP, where a patient will have, some of the parameters but won't have others. Do you have any pearls or how you approach that?
So the Cipro story came out of kidney transplant as well, and there's a small case study that showed that Cipro works. Certainly no randomized trial. We throw it on there just because we don't have anything else. None of the other drugs really work either. So I've seen it used. Do I believe it? I believe it as much as Cidofovir. But I don't. There's, Cipro is a topoisomerase, which viruses don't use. So I don't know why it would work. Now, your second question about differentiating TTP against transplant-associated TMAs. I think the big thing is looking at ADAM TS13 levels. So if the ADAM TS13 levels is low, then that is more the classic TTP, and you should do plasmapheresis. If the ADAM TS13 level is high, then that moves you away from the TTP. Now, the current guidelines are written so that, you know, it wants to make you think that if you have TTP, do plasmapheresis. If you don't have TTP, don't do plasmapheresis. And that's not actually true, because there are things that you're not supposed to do plasmapheresis, such as stack HUS. These are the kids with the E. coli induced HUS. In that population, plasmapheresis is not shown to be effective. But it turns out that in certain subtypes of atypical HUS, plasmapheresis is effective. In fact, there's a subtype called DEAP, which is an antibody-induced HUS. Plasmapheresis is the preferred treatment. So, you know, the line is not as solid as people want to suggest. ADAM TS13 is probably your best bet, and if it's not ADAM TS13 dependent, you know, obviously you lower the calcineurin inhibitor if it's high, and then you try the rest. I mean, but I have to tell you that in refractory cases, we've done the Eculizumab, we've done rituximab, and they don't really respond. Now, we haven't had the chance to use Eculizumab yet, and so that's definitely an option, especially if you see abnormal complement levels. So if you see abnormal C3 or C4, try Eculizumab.
To minimize the effects of the hemoglobinuria from on day 0, do you have recommendations on the amount of pre and post hydration, and does it matter if there's a mismatch of blood type between the donor and recipient?
Usually not. I mean, it really, well, hopefully you wouldn't get acute hemolysis with a ABO mismatch from that, but usually it's dependent on the amount of erythrocyte that is in the marrow, and you could get a hematocrit count on the source to see how much hemoglobin is in there. The fluid, you know, certainly more is better, but then you worry about volume overloading these patients. So I think our standard is a liter before and a liter after